Hello, ladies and gentlemen. Good morning, good afternoon, and good evening to all. Since I can see we have participants from all around the world, and welcome to this important webinar on digital innovation in infectious disease surveillance and response, opportunities and challenges that are organized by the Infectious Disease Alliance. My name is Carl Aryan, and I'm honored to moderate this important webinar today. Please feel free to introduce yourself and your organization in the chat. So we have an outstanding lineup of speakers who will share their expertise today. First, Rodrigo Scottini, the Executive Director at the Infectious Disease Alliance, will open the conversation and give an introduction on the ideas activities. Then we have seven key speakers that I will introduce them before their intervention. We will also have a Q&A session where you will have the opportunity to engage with our experts on key challenges and solutions in the digital health and infectious disease spaces. Anyone who has questions can write in the chat or raise hands, and we will give you the opportunity to talk during the Q&A session. Thank you for joining us in the important conversation. So let's get started. Rodrigo, you have around 10 minutes for your presentation. I have your slides that I can present. Please, when it is needed, tell me to go to the next slide. I would appreciate if you could keep your intervention in 10 minutes. Rodrigo, over to you.
Okay. Thank you, Carl. Thanks, everyone, for joining this important event today. My name is Rodrigo Scottini. I'm the Executive Director of the Infectious Disease Alliance. I'm very pleased to have many participants here today joining us from all over the world. I would like to start with my open remarks and then share some slides with you. So, dear webinar participants, we stand today at a pivotal moment in the fight against infectious diseases. Outbreak response and immunization efforts. However, despite advances in artificial intelligence, real-time analytics, and digital health platforms, significant policy gaps, regulatory challenges, and funding limitations still hinder the full potential of digital solutions. The key barriers include policy gaps and regulatory challenges. Many countries lack clear guidance and data privacy, interoperability, and ethical AI use in infectious disease surveillance, funding shortfalls in digital R&D. So investments in digital epidemiology, AI-driven outbreak modeling, and mobile health solutions remain still insufficient, particularly in low and middle-income countries. Lack of cross-sector collaboration, so the absence of structured partnerships between governments, tech companies, public health institutions, and the civil society weakens the ability to scale digital solutions equitably. Without immediate and coordinated action, we risk missing critical opportunities to strengthen pandemic preparedness and ensure global health equity through digital innovation. Global health security cannot wait. The Digital Innovation in Infectious Disease Surveillance and Response webinar is an important opportunity to mobilize global action and ensure that no country is left behind in leveraging digital health technologies. To maintain momentum, we invite you today to become a member of our community of professionals, researchers, and policymakers dedicated to addressing infectious diseases globally. So next slide, please. So IDA is the voice of civil society globally, focusing on global public health advocacy in addressing challenges posed by infectious diseases. Next one, please. So our vision is to reduce the burden of infectious diseases in this NGO-led initiative and improve NGO civil society-led initiative and improve access to healthcare. And our mission is to unite civil society organizations globally. Next one, please. So what we do, so we promote action in advocating for impactful policies and sustainable finance. We do have some events that I'm going to show you later. Unite civil society to combat infectious diseases, promote healthcare system strengthening, foster cross-sectoral collaboration and One Health, promote equity and amplify underserved voices. I'll probably have also insight on membership. So for possible members, you can get access to critical tools, opportunity for global alignment, and we support your activities with resources and training. Next one, please. So collaborative partnerships, I do have to mention that we are not only a platform for discussions and education. We do actively link actors to build partnerships and activities together. Next. Our members are civil society, as you can see here. If you're coming from a civil society organization, please do not hesitate to contact us for membership in IDA. Our supporters are foundations, private sector, and governments, and engagement partners are policy actors on international and national levels. Next one, please. So here you can see the benefits of becoming a member, representation committees, event participation, allies updates. You can also share your updates. You can join in advocacy activities and get access to resources. Next. So those are committees. You can see that digital health is one of them, and we have events around all those committee areas. So please keep yourself tuned to our activities and feel free to enroll and register to our activities. Next one. So those are the events, physical events that you're organizing. Next one in WHA. So if you're attending Geneva events, feel free to reach out to us. You have 2 roundtables there. Then we have an European Parliament event on the 10th of June on vaccine hesitancy, UNGA event on UHC, World Health Summit on finance, and One Health Conference in November in Brussels. So the next slide is about the webinars. Here you have the first one in April on digital innovation. We had some other ones that are also available for you to see for March, and please register for the upcoming ones that are of interest. Yes. This is our organization. I'm not going into details, but those are teams. You have also several team members participating here today. Feel free also to contact them, add us into your network, and please feel free to also introduce yourselves in the chat. I'll also do myself, share my LinkedIn so we stay connected for future activities. Next one. So our policy strategy is also available on the website if you're interested in hearing and understanding more of what we do. You can see that our strategic goal is to facilitate civil society efforts in achieving SDG 3.3. Yes, and I think that was it, right, Carl?
Yes, this is your last slide, actually.
Yeah. Well, thanks everyone for attending you today. I'll give back the word to Carl to introduce Dr. Helena.
Yeah, thank you, Rodrigo. It's my pleasure to have a chance to work with you and the Infectious Disease Alliance. Now, let me introduce our first speaker, Dr. Bhupendra Kumar Rana, who will present from India. He is a member of the board of directors at the International Society for Telemedicine and eHealth and the CEO of Quality and Accreditation Institute. Bhupendra's topic will be about the role of digital health quality standards in public health and infectious disease area. Dr. Kumar, you have 15 minutes for your speech, and now over to you.
Okay, just let me know when the presentation is up. Is it up?
No, not yet.
Not
but
yet?
Yeah, we can see that. Yeah, we can see that.
You can? Okay.
Yeah. But,
Thank you.
You should put it, yeah, on your presentation mode.
Okay.
The bottom right.
It's in the bottom right. It's next to the line there in presentation mode. To the left, the bottom.
Bottom.
Yeah, it's just a symbol. It's a white symbol on the bottom. Yes, this one.
Is it up?
If you can click again.
Not yet.
But I can see it here.
No, we cannot see. But if you zoom in, maybe you can see the slides that you're showing. Yeah, if you zoom in a bit, they should be fine.
Okay. Okay. It is up now?
No,
We can see your slides, but it's not in the presentation mode, actually.
It's not in presentation.
if you press F5 in your computer, it might make it in presentation mode. I think we lost him.
Yeah, I think you lost the control. Yeah, I can see that. Again,
It's clear.
You're on mute, Dr. Kumar.
Yes, it's not taking the full screen. Come on, I don't know.
It should be fine.
Yeah, it should be fine. Yeah.
The challenges of digital health and digital.
Yeah, that's the big problem. Particularly the good is full screen. Is it up now?
It's not full screen, but yeah, you can continue with this. No problem. You can see your slides.
Yeah, you can see my slide, but it's not moving.
Yeah.
Oh goodness, I've never come across this situation.
We can see it. That's okay.
But it's not moving, Rodrigo.
You can just click on the slides on the left and move it from there. You can choose it. Yeah, and if you click there.
There's the dots coming actually.
We can maybe move to the next speaker, and you can send our presentation to us, and then we can show it to you.
I think
Yes.
that's okay. Yeah, that's fine. I'm
Okay.
sorry. I just sent it to you.
Thank you.
So let me share my screen again and introduce the next speaker. Okay. Can you see my screen now? I think. Okay. So now
Yes, you can.
move from India to the US, and I have the pleasure to introduce our next keynote speaker, Dr. Patricia Mitchell. She's the CEO at the Health Enabled. In 15 minutes, she will show us some works have been done in the area of digital health and infectious disease surveillance with a focus on gender and immunization. Patty, over to you.
Great. Thank you, everyone. Can you hear me?
Yes, we can hear you.
Wonderful. It's really great to be here, and thank you to Carl and Rodrigo and the Infectious Disease Alliance for having me. If you go to the next slide. So I'm going to share a little bit about Health Enabled, some of the work that we've been doing over the last, I want to say 6 or 7 years with Gavi, the Vaccine Alliance, on various aspects of digital health and data for immunization as well as disease surveillance. And then share a little bit about the state of digital health enablers. Health Enabled has the privilege of being the technical lead and facilitator for the Global Digital Health Monitor. And so wanted to share some insights from what's happening at a national and global level across different countries. And then talk a little bit about some thinking around emerging technology, including AI and machine learning for disease surveillance and immunization. So if you go to the next slide, so Help Enabled, we're 10 years old. We are a nonprofit that focuses on nationally scaled digital health ecosystems and the enablers for digital health. And a lot of our work has really focused on thought leadership, on developing strategies, including Gavi's digital health information strategy, building global goods such as the Global Digital Health Monitor, and then measuring impact. We do a lot of large-scale effectiveness studies to evaluate the impact of digital health on various health outcomes, including immunization and disease surveillance. If you go to the next slide. As I mentioned earlier, we have this state of digital health work as well as the Global Digital Health Monitor. And if you go to the next slide. And I just want to share some reflections. So a lot of people talk about COVID-19 as being this sort of like catalytic moment for digital transformation of health systems. And it was a moment in time in which a lot of countries applied digital technology to monitor the COVID-19 pandemic, as well as to support access to immunization. There were some really innovative approaches to doing everything from monitoring public sentiment through digital social listening, and some really good applications of artificial intelligence. And but what we learned through the COVID-19 experience is that a lot of people had, a lot of countries had digital health infrastructure already in place, but most countries actually bypassed their digital health applications and implemented entirely new systems to monitor COVID-19. And so and a lot of this is because a lot of the health systems are fragmented, that the people doing emergency monitoring and surveillance are very different than the people that are doing kind of like routine health information systems implementation, as well as certainly with a lot of the programs that we work with, the EPI program, the immunization program sits in an entirely different part of ministries of health. And so COVID-19 sort of taught us that on the one hand, you can really scale digital health and do digital transformation when you throw a lot of resources at it, set it up in a different part of your institutions, and but it has not necessarily translated into feeding back into strengthening the overall digital health ecosystem. One thing that it did do was that it did show to countries that they could do digital transformation at significant scale. And so even that muscle memory, I think, has been a very positive experience for a lot of countries. And it really showed the value of having access to data and using data effectively. If you go to the next slide. And so in our work with Gavi, the Vaccine Alliance, we've done, our first engagement with them was to do a large-scale effectiveness study of Rapid Pro, which UNICEF was implementing in Indonesia as part of a measles rubella campaign. And what we learned in that, initiative was that, they did a very good job of scaling the platform. The platform was incredibly effective at providing transparency into the immunization campaign. It enabled them to track coverage, identify where there were problems and where corrective action was needed for the measles rubella vaccination campaign. But what they ran into in that implementation was that political forces that were driving vaccine hesitancy in certain parts of the country were derailing the campaign itself. And so, as with all things technology, it's only as good as the systems and the information, that it's there to help connect and support. And if those things are not in place, even if you apply technology and data to these things, they're not going to be as effective. So using that experience and some other experiences that we had with Gavi and really landscaping, different aspects of the evidence in terms of where is digital health and data actually showing that it can contribute to improved immunization outcomes. These sort of 6 priority areas and then 2 additional priority areas were identified as some like core focus areas. They included everything from using geospatial data to identify, areas of countries that are not on maps where populations live, but are very rarely accessing services. So 0-dose children who've never been immunized, don't appear in any health system, and really trying to make sure that we can reach them and give them access to immunization, supply chain information systems, real-time monitoring of campaigns, as well as effective subnational data use, supporting demand for vaccine, as well as improving vaccine confidence, and electronic vaccine preventable disease surveillance. And then 2 additional areas where they've prioritized investments are digital payments and financial management, as well as digitally supported health worker learning and performance management. And then they also wanted to take a very targeted gender intentional approach, because we know that when women are engaged in leadership roles, as well as in very proactively engaged in health systems activities and policymaking and technology development, that the effects and on outcomes is significantly improved. And I'll share some research findings in a little bit. If you go to the next slide. And so I won't spend too much time here, but we were really pushed when we were working with Gavi, and these resources are available on the Gavi website, to make the case for digital health information investment in immunization. And these were some of the key areas where the real value of digital health was highlighted and prioritized. If you go to the next slide. And then as part of the vision for Gavi, they really wanted to have this sort of like focus on, digitally transforming, immunization services with a gender intentional approach, and using immunization as an entry point into primary health care. That immunization is a really good use case to get people sort of registered and engaged in health systems and onboarded into other prevention and diagnostic and treatment services. If you go to the next slide. And then they also really pushed hard to make sure that whatever was being developed and designed at a global level could be really operationalized at a country level. So we developed this sort of country roadmap approach and methodology to work with countries to do the analysis and do the prioritization of, what are the most important digital health interventions against their prioritized immunization outcomes that they're looking to achieve, looking at their digital health maturity, as well as doing gender analysis as part of their digital health design and implementation. And so we kind of worked on this methodology and implemented it across different Gavi-supported countries. And these roadmaps are not Gavi roadmaps. They're really national roadmaps for countries to look at where digital can help improve immunization, particularly as an entry point into primary healthcare. You go to the next slide. And so we are currently in the process of evaluating and doing some large-scale effectiveness studies around the prioritized areas that that Gavi has identified. And what we're finding is that, yes, like, you know, in DRC, using this sort of geo-enabled microplan approach is helping to identify communities that had not been, you know, included as part of you know, health systems, as well as immunization programs. We're seeing that you know, data, you know, is being increasingly available at subnational level and used. We did a 3-country study on DHIS2 in Mali, in Uganda, as well as in Bangladesh, and the findings were really quite remarkable. We know that real-time monitoring of campaigns, you know, does help improve your campaign effectiveness, as well as, you know, identifying where problem areas are. Digital supply chains are showing, you know, reduced health facility stockouts and better logistics management, and that, you know, particularly during the pandemic, but also since the pandemic, you know, using digital social listening and the ability to track public sentiment enabled a lot of countries to do more targeted communication and service provision, particularly with the increase in vaccine hesitancy and in anti-vax sentiments, particularly through social media and other communication channels. But what we're really challenged by is, and this is, I think, interesting for this conversation in particular, is that there is not a lot of evidence around, you know, the use of digital innovation for disease surveillance. And I think a lot of it is that we have very fragmented, you know, ecosystems where disease verticals kind of manage their own information and data. So, you know, HIV has some of the most robust data out there, tuberculosis a little bit as well, you know, but we don't have a comprehensive approach to, you know, disease surveillance as well as outbreak management. And a lot of this is because of how it's been organized within health systems, as well as how, particularly for low and middle income countries, it's been traditionally funded by external donors. And this is incredibly problematic, and hopefully, you know, things will start to change. And I think it gives us a good opportunity to start to rethink, you know, global data ecosystems and health data ecosystems. If you go to the next slide. So gender, we know that, you know, we're learning through different, you know, evaluations and research studies that things like women's mobile phone ownership are actually strongly correlated with improved primary healthcare outcomes. And this is not surprising because of the social determinants of health. We know that maternal education generally leads to better family health as well as child health, you know, and some of these other areas. What we also know is that gender is not being taken into account in a lot of digital health interventions and policies. And this is a problem because women are not being included as part of technology design. They're also not being included as part of policy development. They're largely not in supervisory or administrative roles. And yet women constitute the bulk of frontline health workers. And so we have a problem here in our ecosystem. If you go to the next slide. And what we found is through our research that we've been doing, these large scale effectiveness studies with Gavi on immunization outcomes, is that in interventions where you do take a gender intentional approach, you are able to reconfigure your approach to your programs and do it in a way that leads to improved health outcomes, or more significantly improved health outcomes. We did a study in Pakistan where the intervention proved effective, that it contributed to improved health outcomes. However, the way the intervention worked is that female caregivers were expected to give their mobile phone numbers to male vaccinators. And so a lot of female caregivers refused to give their mobile phone numbers to male vaccinators. And therefore, those children did not get registered into the immunization registry program. In DRC, there was an initiative funded by the Canadian government that insisted that they have a gender intervention as part of a subpopulation. It wasn't even like that they did this, throughout their whole intervention, but in their subpopulation, they took a more targeted gender intentional approach. And what we found was that in that subpopulation, they were much more able to improve immunization outcomes and reach of their program. And what they did was they recruited more female vaccinators, and they also included women in the organizing committees of the program, and they partnered, which I thought was spectacular, with the Ministry of Gender. And because the Ministry of Gender in a lot of countries is already doing, social programs with women's groups, etc. And you can almost immediately tap into like an incredible resource that can really benefit the health system. But this is not happening, as significantly as it could and it should be. If you go to the next slide.
Just as a reminder, you have 3 minutes more.
Sure. Yeah, I'm almost. And then I just wanted to share a few words on, AI and machine learning, because everybody is gaga over AI and machine learning. We did a couple of landscapes on this, and what we found, is that there are some, use cases where AI and machine learning, is making sense, particularly in the immunization space and the disease surveillance space. If you go to the next slide. Some of the key ones that we have identified are, optimizing immunization systems, supply chains, doing more targeted planning, service delivery and monitoring, improving vaccine demand, and addressing misinformation and disinformation. So we are seeing some really good applications of AI and machine learning in the social listening space, as well as improving and providing more targeted health worker guidance and training, through virtual assistants. And I think this is another really important and interesting area for exploration and development. If you go to the next slide. These are some examples, and my slides can be made available after the presentation. And then if you go to the next slide. But one of the big challenges that we're seeing, and we found this through the Global Digital Health Monitor, is that a lot of countries do not have the regulatory environment for AI and machine learning. And so, we really need to think about how do we mentor and support countries to kind of be onboarded into the global AI machine learning ecosystem. That not AI and machine learning should not be applied to everything. and you need to make sure that you have the right kind of safeguards and guardrails. And, and what we're finding as well is that the AI that is proving the best is with a human in the loop, that you really do need, people with strong technical expertise to really tease apart how much of what is being produced through this sort of AI approach is real and true, and how much of it is not so real and true. And we need more and more evidence generation and evaluation around the effects of this, and not just for accuracy. Like the just because something does what it says it's supposed to do does not actually mean it will have the reach and the impact that you want it to have. So making sure that an equity approach is taken, that we're really looking at, is the data reflective of the populations that we're trying to serve, and is it being implemented in a way that's really going to benefit the people that we really want it to benefit. So I will, if you go to, I think my last slide is just to say thank you, and there are some resources and some links that you can access, and yeah, and back over to you, Carl.
Yeah, thank you, Patty, for sharing your insightful and valuable ideas in this webinar. Now we will come back to Bhupendra. I have your slides ready. Let me just refresh my page. There it again. I'm sharing the slides now. Yes, over to you, Bhupendra.
Thank you, Carl. Thank you so much. Apologies for technological glitch in the conference and technological conference, and this is what happened. Thank you, Patricia. And first, thank you, Rodrigo, for an excellent overview of IDA activities. And Patricia, for excellent, very technical and very informative session. So I will take you through all to a little different presentation, which is about three activities in my session, is about ISFTH, QAI, and how accreditation standards can support digital innovations in infectious disease surveillance and response. So next slide, please, Carl. So this is what I have taken it to three sections of presentation about ISFTH, QAI, and digital innovation in IDS. Next, please. So International Society for Telemedicine and E-Health, actually founded in 1997 in Switzerland, is a very simple mission to facilitate the international dissemination of knowledge and experience in telemedicine and e-health, and providing access to recognized experts in the field of worldwide. As Patricia mentioned in her presentation, a lot of use of technology, digital health and all, but it's time become very difficult when we need some experts. So I think ISFTH is very good platform for networking and access to those expertise whosoever is requiring. Next, please. So this is a global organization having a global network of digital health stakeholders across the globe, coming from different backgrounds, providers of telehealth services, to building a telehealth technology platform to deliver telehealth, and also the manufacturer and the providers of digital health technologies, including mobile health. Next, please. So it's the mission taking forward is to going beyond networking and to offer partnering on specific activities and services, which includes different trainings, courses related to virtual care, telehealth, and endorsement also related to different educational and training programs. Also offering legal insights and assistance, particularly for cross-border regulations, while offering digital health or telehealth. Very happy to say that ISFTH is involved in Global Telehealth Community of Practice, GTCOP, along with several other national and international organizations, and also providing opportunity for investing and funding opportunity for digital health organizations through IFCC, which is an international organization, a part of the World Bank. So there are opportunities for the members to seek funding as well. Also supporting compliance and regulatory mechanism for telemedicine and e-health companies. And ISFTH is also a non-state actor in official relation with WHO, which gives access to a lot of international activities and the participation in meetings and communities. Next, please. So as a part of disseminating information on training, education, skill development, and also helping building the capacity In telehealth, there are provision of providing continual medical education on different topics. Also, a provision of endorsing different courses, educational courses, training programs, to give the credibility and wider acceptance of those training and education materials. Also, supporting in collaborating manner with institutions, universities, and other which are offering digital health courses, organizing different events, webinars. Also, a very encouraging event which is related to the students. So, different students participate in contests, presenting their projects on telemedicine, e-health, digital health, and they are awarded accordingly and recognized for their contribution. And telemedicine education advancement through micro credentials, the team activity, which is also a network of global experts. Next, please. Standards, accreditation, certification, and quality assurance. In any field, standards play a very crucial role, and therefore ISFTH is also involved in those activities through their members like QAI, URAC, Joint Commission International, which are some of the members in this area. They also help in coding the different clinical practices to help, ICD, and also participate in different committees of ISO, International Organization for Standardization, in formulating international standards related to telehealth and digital health. And also participating in IEEE Standards Association, which is a global organization for developing electronic standards. Next, please. So I seek the support from members to join the ISTIP Global Digital Health Network. It is helped to expand your networking. It helps to help support networking in your own areas and also diverse field, also to support collaboration and also to provide access to different services being offered by ISTH and their members across the globe. Next, please. So now coming to the second part of the presentation about Center for Accreditation of Health and Social Care under Quality and Accreditation Institute, which is a member of ISFTH and provide accreditation to different organizations. Next, please. So QI is recognized internationally by International Society for Quality in Healthcare, ISQA, External Evaluation Association, which provide accreditation to accreditation bodies, which gives a recognition to the accreditation bodies globally and also equalates. Next, please. So at QI, we have a complete care continuum of patient for standard accreditation, starting from pre-hospital to hospital and post-hospital, and particularly in post-hospital and pre-hospital, where the role of telehealth comes in. So we have a specific standards for telehealth services, and we are emerging as a specialist accreditation body because we are developing standards in very specialized area like home care, telehealth, and also some clinical areas like stroke care and IVF. Next, please. So this is the menu which we have. Difficult to read perhaps, but we have 19 standards developed, starting from a single doctor clinic to a tertiary care hospitals, and then also for clinics and telehealth, emergency department, stroke care, also for ambulance services. That's why I say pre-hospital, where the role of medical transport organization, the ambulance services, emergency services comes in. We have a standard. We have also standard for a specialized area like IVF, dialysis, hair transplant, and also bone marrow transplant. And I think each standard actually covers a role of digital health and telehealth using different standards. Next, please. So now, as I mentioned, we have a specific program for accreditation of telehealth service providers who are involved in delivering the service through telehealth or digital health. Next, please. So as we know, the COVID-19 pandemic actually has taught us several lessons, and the evolution of telehealth or digital health sparks like anything. It was existing before, but after COVID, it becomes like multiplied several times. Users goes up, and it highlighted disparities and global vulnerabilities. As Patricia also mentioned in some of the slides, that the diversity, inclusivity, and also participation of women were very rare earlier. But now I think that things are changing because this diverse situation like pandemic, we learn from those situations that how we can integrate different components into our healthcare delivery services and systems. And it's also highlighted that there are opportunities for digital health solutions so that we can really provide a good care to our people. Next, please. So digital technology, actually, I would say the integration of digital tools, which are coupled with transitional surveillance methods. When we talk about communicable diseases, disease surveillance, or even the response to those diseases, the use of digital tool is very, very paramount, and it can help in creating a robust and accurate disease management system. Because if you do something which is done in terms of thousands, when you scale it up to 100,000, the scenario changes, and then expansion and the elaboration of those type of scale is difficult to handle manually. And so therefore the use of digital tool, the use of electronic systems is become very, very important and paramount in making things happier and easier for us. Next, please. So the future of telemedicine, and slides from coming for 3 years back, to see how the transition from adoption of telehealth and telemedicine grown in all areas, whether it's related to the chronic illness or in non-chronic illness, and even in general patients. So it shows that the adoption has gone up, and I think it is continuing in many countries. And now we will couple with the digital tools, not just telehealth or telemedicine, but now it's an ever-evolving system for digital, which is more, more gross and more fundamental in understanding the systems. Next, please. So digital innovations, when we talk about some of the innovations, what we learned through different framework available internationally, we have seen some systems which are real-time monitoring systems. Use of technology, when you can monitor what's going on in this part of the country or this part of the world, we can really make it happen. And artificial intelligence and machine learning, AI, ML, actually now the talk of town. Everybody is talking about those things. But again, there are challenges in that and adoption, how to make use of AI in machine learning in our own practices, how to make a balance with what is ethical and what is not. So I think there are a lot of challenges, but there are tremendous opportunities using AI and ML. Obviously, wearable devices also gone up in usage. Also, the manufacturers of medical devices, including wearable devices in patient care, has already gone up. They are now become very sophisticated. But again, there are certain challenges as well. We were talking about IoT devices earlier, but now we are talking about internet-based surveillance, where we use an electronic system for collecting information and data and use for surveillance activities. Again, then in terms of response also, remote patient monitoring. And during COVID time, this has been tremendously used, where the doctors were not available in the hospitals and the patients are all across, not visiting. So RPM, and particularly like ICUs, ICU is being managed now, is increasing. They are monitoring through a remote system, and so RPM is going up. Networking of experts, yes, that's become one of the fundamental development in this world, where the people have started talking to each other on common agendas and common problems, and it's become a pool of expertise around the globe. Next, please.
Dr. Kumar, you have 2 minutes more.
Yes, please. Next, please. So when we talk about challenges, related to the opportunities, we have problems as well, but we should not be afraid of them. We can take care of them as we move forward. So in relation to challenges, we have issues related to data quality, ethics, validation, infrastructure. Whether we talk about any of these things, these challenges will always be there. Next, please. So when we talk about surveillance and response, obviously data collection, they're related to challenges, accuracy, security, confidentiality, diversity, inclusivity. These are the challenges when we start collecting data for any surveillance mechanism. And then build up the analysis tools, availability of the right experts, the personnel, the quality, the volume of information available, how to deal with that, keeping the information confidential, patient data, an out-of-box strain, maybe a new strain comes up. We don't know when a new strain develops. And then interpretation, we need expertise. We need the availability of those expertise. It's not that easy. So response measures such as vaccinations, quarantines, community engagement, awareness, we have seen during COVID times, and I think they need to be continued on a regular basis through a resource systems. And resource-limited settings, they have their own extra challenges. Next, please. So when we talk about the standards, next. So it gives a framework. We say accreditation standards provide structures, process, and outcome approach. So we need to build on the governance, we build on the human resources, we build on the facility and risk management. We talk about information management system, how to collect information, how to manage the entire information system. Also continuous quality improvement. Because things are not static, they are ever evolving, they are ever growing, they need to be monitored on a continuous basis to see whether we are improving or we are not. Patient assessment, particularly telehealth and telehealth and medicine, when we talk about how we assess a patient, is that reliable? What are the things which we need to consider when we are assessing patient compared to when we see a patient face to face? And rights and education of patient. Yes, every patient has their own rights. They have a right to privacy, confidentiality, refuse to care, whatever is applicable in a hospital setting or clinic. Similarly, it is applicable to a telehealth system or telehealth delivery systems. Medication prescriptions. Yes, medication errors are the second largest cause of death around the world, or the most significant contributor amongst the medical errors is medication safety, medication prescriptions, whatever it is. So I think that's very, very important thing, particularly telehealth talks about how to take care of those issues through standards. Digital health application, yes, what system you use, what platform you use, how you ensure the confidentiality, data security, all these things need to be considered. Next, please. So in the nutshell, at the conclusion, data uniformity, protocols of standardization, efficient communication, higher accuracy of data, optimum resource utilization, ethical and regulatory compliances, support emergency situation, natural or man-made, whether it's a pandemic or flood or disaster, good global networking and collaboration. So standards, all these components are ingrained in the accreditation standards. And that's why I can say that the standard supports infectious disease surveillance and response in a very, very technical and administrative manner. Next, please. So I think that's the end of the presentation. I would request if anyone needs any information, there are the email ID given for in front of you. You can note down. You can seek information about ISFTH or QAI. We would be very happy to provide. Once again, thank you, IDA, for having me here. Thanks, ISFTH, for providing me this opportunity as well for sharing some of the ideas and views related to standards and digital health. Thank you very much. Over to you, Carl.
Thank you, Bhupendra, for your insightful presentation. And now we have 4 speakers from Digital Square in PASS. They have around 14 minutes for the group presentation, and they will talk about their interesting project in Africa. In this webinar, we have Linda Taylor, the technical program manager in Digital Square PASS, and we have Jidon Sarpong Nyameke. I apologize if my pronunciation is not correct. And we have Joseph Mtenje, and also Isaac Sahara. And I have your slides ready. Please let me know when we need to go to the next slide. Over to you, Linda.
Great, thank you, Carl. And yeah, hello everyone. Good morning, good afternoon, good evening, and thank you. We're really pleased to be here. My name's Linda Taylor, and I'm a technical program manager with Path Digital Square. And together with Gideon, Isaac, and Joseph, we're going to be telling you and sharing some of our insights around the Digital Innovation in Pandemic Control project. I am actually going to switch my camera off now, having done my intro, because I'm finding it terribly distracting to see myself on screen. So this way I can actually focus and make sure I'm talking sense. But yeah, next slide, please. Right, so this project was funded by the German Federal Ministry for Economic Cooperation and Development, BMZ, implemented by GIZ, and we've got one of our colleagues on the call here with us as well. And its primary focus was really on strengthening immunization systems as a key component of a much more resilient and sustainable pandemic-prepared health system. So we worked very closely with a number of different partners. This included UNICEF, who was supporting this type of work in Sierra Leone, with the Regenstrief Institute, who was focused very much on the capacity development pieces, the Robert Koch Institute, focusing on monitoring and evaluation aspects, and then with PAHO, the Pan American Health Organization, who was supporting this type of work in Peru. And this began back towards the end of 2022, and it's set to conclude in August 2025. Next slide, please. So within this initiative, Digital Square's role was really focused on strengthening immunization systems in 3 countries, Ghana, Malawi, and Tanzania. And I am going to be handing over shortly to my colleagues who are going to tell you about that in a lot more detail. But I think really the key takeaway here is that this was very much a country-led initiative. So it was designed to align with national government priorities and also working with their existing digital systems. So rather than introducing new systems, we worked closely with the respective ministries to enhance what was actually already there. So in Tanzania, we did an assessment and then strengthened the existing Go Thomas immunization system, which has been in place for quite a few years. And then in Ghana and Malawi, we partnered with local software developers who built immunization modules within existing government platforms. So in Ghana, this was a new module in the child health module in DHIS2's eTracker. And then in Malawi, this was a new module within MAHIS, the Malawi Health Information System. Next slide, please. So beyond this country-specific work, there were also a few cross-cutting priorities, one of which was developing a global immunization product suite. So this is a tool designed for broader use beyond these countries. I'm going to be telling you a little bit more about this later on. As always with these type of projects, a very important component was strengthening local capacity. And this was done by providing training and resources, also collaborating with Regenstrief Institute to provide training to Central Ministry of Health staff, trainers, and of course the end users themselves. And then the third piece was really promoting gender equity in digital health. So really ensuring that women are equipped with the skills, with the information, but also with the supportive networks that they need to be able to actively participate in this field. And I'll tell you a little bit more about that also right at the end of this presentation. Next slide, please. But I think before we dive into the project activities and the digital systems that we've been building, I just wanted to take a moment here to pause and reflect on why we're here. Because while this technical work is really important, it's also really crucial to remember the bigger picture, that this is a small piece, but ultimately we hope to have an impact on improving people's lives. So child vaccination is really one of the most effective ways to protect children from life-threatening diseases, preventing horrible illnesses such as measles, polio, pneumonia, and also reducing child mortality and ensuring healthier development. Vaccination not only safeguards those individual children, it also, through herd immunity, helps to prevent outbreaks and also protect those who, for whatever reason, actually cannot be vaccinated. So it's a really cost-effective public health intervention. Next slide, please. So the DIPC project helped to strengthen these systems in line with WHO's guidelines and recommendations. Next slide, please. And so this brings us to the DAKs, WHO's Digital Adaptation Kits. Next slide, please. I think many of you might already be aware of the SMART guidelines in the DAKs, but for those of you who aren't, I'm going to give you the super fast overview and try and explain what these are very quickly. But the DAKs are part of WHO's SMART guidelines. So this is an initiative really designed to improve the way that clinical guidelines are translated into digital health systems. And, you know, traditionally, over the last couple of decades, this process has been actually really difficult, sometimes painstakingly slow, and honestly, sometimes poorly executed process. So this has raised concerns about patient safety, about usability, and about effectiveness of those systems. So SMART Guidelines really tries to address these challenges by providing a very structured way to digitize health recommendations. So the goal is really just to make them more accurate, making sure that they're faithfully represented, and through that, making sure that the systems are safer, and also then just faster to deploy. So speeding up that whole translation process. Next slide, please. So what are the different components within the DAC? I think those of you with a business analysis or a software development background, you'll see these are something that look really familiar. So a DAC is really just a standardized way of representing user and system requirements using some human-centered design approaches as well. So really making sure that they're very comprehensive and very clear. And those key components include user personas and scenarios, so descriptions of anyone who is using or impacted by the system, including the end users of the system and how they might interact with it. It also describes the business processes and workflows, so how work is actually carried out, so making sure that there's alignment with real-world operational processes. And then one of the most important pieces is the data dictionary, which describes the core data elements, how they fit within the workflow, how they might be mapped to health data standards, and how they can be used to generate some of the key performance indicators for reporting and for monitoring purposes. There's also a section on decision support logic, and then there are the functional and non-functional requirements. So by design, these are very high level, but it really does define some of the core capabilities that any electronic immunization system should really include. Next slide, please. So here at Path Digital Square, we're very strong advocates for WHO's DAC framework because at its core, it really ensures that digital health solutions are built right so that they improve efficiency and are safe for patients and healthcare workers to use. And rather than starting from scratch, it really provides a good validated starting point that can then be adapted for different country-specific needs. And this is what we did under DIPC. So it promotes consistency, standardization, which always enables better collaboration and coordination. It can mean that your requirements gathering process is quicker, more efficient, and usually also then more cost effective. Also remembering that if you don't have well-defined requirements, you actually can't test effectively in terms of assuring the quality of your particular system. Also, another benefit of the DAC is that having clearly defined requirements can be a resource that helps government and implementers to actually evaluate potential tools against these to see whether or not they meet their needs. And of course, finally, that those core data elements, so this consistent representation really helps to support systems interoperability. Next slide, please. So some of the key takeaways. So the WHO's DAC format is, in very simple terms, a standardized way of representing user and system requirements. So there are quite a few official versions of the WHO DACs available on their website for things such as family planning, ANC, HIV, and the newly published immunization DAC. But just remembering that these core principles and this format is really something that can be adapted to any type of health system requirements documentation. One thing that those of the more eagle-eyed among you might have noticed is on that earlier slide, the official WHO DAC was actually only published this January, a couple of months ago. But of course, our project started well before that. So because we really didn't have the time to wait for this to be released, what we did is we developed our own version using the standardized format. And we were able to do that because of the expertise within our PATH team. So we have colleagues who were actually part of that WHO process working on the official DACs. So we did have some access to some of those early drafts. But also the WHO's work was built on quite a lot of it was built on the BID initiative from Tanzania, which I think was around about 2014 or so, Path was also a part of that. So what that gave us was a strong foundation of both the institutional knowledge and a lot of resources that we could pull on. So we created this generic set of common requirements for immunization, and then we actually localized those for the 3 different countries. So I'm going to be handing over now to my colleague Gideon. He's going to be telling you a lot more about how we actually did that in Ghana. So over to you, Gideon.
All right, thank you so much, Linda, and hello again, everyone. My name is Gideon Sapon. I'm a Technical Project Manager, Digital Square Path. I lead the DIPC project in Ghana. Next slide, please. So for the next couple of slides, I am going to walk you through the experience in Ghana and the project activities under the DIPC. Ghana actually started active engagement with the government by jointly conducting a landscaping exercise to really understand what are the digital tools that are used for immunization services in the country. We arrived at a couple of results, and out of that, we came up with these 3 key objectives. The first one is to enhance the DHIS2 tracker so that it can serve as the Ghana's national scaled immunization registry. And doing so is to ensure that we are improving access to data for decision making. Again, you'll also agree with me that once systems are enhanced, there is the need for us to also build the capacity of the health worker force or the end users that are using these systems directly, so that it can also promote the continuing use and adoption of these systems. The other key thing that we found was the duplication of efforts and the systems that are working in silos. So systems were not talking to each other. And the whole idea was for us to be able to ensure that how do we bring these systems together through interoperability. We started this process by developing a detailed requirements for interoperability so that the government can have these requirements to potentially evaluate digital systems in the country. Next slide, please. I'll be focusing on objective 1 and 2, and this is how our implementation has been so far. We have been able to enhance the child health model of the tracker such that it's now been able to capture relevant routine immunization vaccines. So for example, BCG, OPV, PCV, MR, all these routine vaccines are now being able to capture and record it effectively through the enhanced system. And this has been done in a way that the program has been structured in a staging phase, such that, for example, where we have OPV, for example, OPV that is given for 4 different doses. So at birth and in 6 weeks. So in 6 weeks time, if the baby comes back, the system automatically will unlock this particular feature so that the user can enter the required results in the system. Beyond that, the scale of our project in Ghana is huge, but we are taking it slow, staggered in phases. So in phase 1, phase 2, and phase 3, we are currently in our first phase, which is phase 1, where the target is in deploying in 2 regions, which is a Ahafo and Volta region. So far, we have been able to train 1,487 participants or health workers across 731 facilities in 24 districts. And the cohort or the kind of health workers that have been trained varies around health information officers, disease control officers, among others. We have also supported the Ghana Health Service to plan the deployment in 8 regions, such that our focus is to be able to cover about 100 districts and then the planning to manage about 300 clients. Next slide, please. Next slide. Yes. So this slide really focuses on the feedback that we've received from the end users after deployment. one of the things that we have really, or we keep hearing, is the efficiency of the enhanced system, such that it has even reduced the speed up or the time that it takes for registration to happen. And again, it has also improved the vaccination tracking and obviously enhancing the reporting of the system. I mentioned about the program being staged, and this has really, it's also because of the streamlined workflows that has been implemented and overall boosting the overall productivity of the digital system that has been developed. One of the key things that I would like to highlight here is the collaboration with the government. I started by saying that we collaborated with the Ghana Health Service throughout our process. And this is really a key process that I would like to highlight. If you really want to deploy a project in Ghana, there's the need for you to actively engage the government to ensure that you're having the government's commitment to scaling and addressing the challenges in the country. Next slide, please. Our key focus right now as we move ahead and the opportunities we are looking forward to is to ensure that we will be able to scale up the enhanced system across the country, as mentioned earlier, based on phases. Beyond that, one key thing that we keep hearing during our monitoring visits is the unlimited or limited hardware or tablets. So, for example, a facility or a regional facility seeing about a minimum or average clients of 40 a day, and then having just a single tablet at this particular service point really shows that there is the need for us to be able to procure additional tablets for efficient data capture at these service points. And then finally, it's also touched on the need for us to be able to continuously enhance the child health model so that we can integrate with other key systems in the country. So this is the overview and key activities that we've been able to cover so far for Ghana. I would hand over to Joseph for him to speak about the implementation in Malawi. Joseph, you are on mute. If you can unmute, please.
Oh, sorry.
Awesome.
Good morning, good afternoon, good evening, everybody. My name is Joseph Mtenji. I'm the technical project manager for the DIPC project in Malawi. So I'll speak about the DIPC implementation in Malawi and the progress that we've made so far. Next slide, please. So the DIPC project in Malawi had two main objectives. As Linda had spoken, there are overarching objectives, but in Malawi we had two that we had zeroed on. The first one was to build and deploy the electronic immunization registry within the hospital-wide information system that is for Malawi. That is called the Malawi Healthcare Information System. With that, the outcome is to improve access to data for decision making, and that the effectiveness of healthcare workers at the facility level is improved. The second one was to strengthen the health worker capacity and also the central level, the digital health division capacity, that they should be able to sustain the system even after the DIPC project is done. Next slide, please. So after we had a discussion with MOH on their priorities for the immunization on the digital space, they had mentioned that they already had a plan before the DIPC project came, that they wanted to have an immunization registry within the MAHIS, the Malawi Healthcare Information System. And with that, we had planned that it will be deployed across the 47 facilities in 3 districts. That's in Salima, Ncheu, and Chinji. The reason these 3 districts were selected was because healthcare workers at the facilities were already using some sort of digital tools, and we thought it would be easier to deploy at these facilities and have a good takeoff of the system. So we had targeted about 311,000 clients, and from those facilities we had 1,200 healthcare workers. These are health surveillance assistants, healthcare workers that actually do the actual immunization on clients. And after the system had been deployed, that was in November, December, we had a very good uptake of the system. We had 32,000 clients registered by March. That's within just over 3 months of the system being introduced. And we had 25,000 clients were vaccinated, and that's recording over 166,000 doses. So with those doses, there were some back data entry for clients that were not previously recorded in the system. So when a client comes with the book, they would actually capture all the vaccines that the client has received prior, even before the system. Next slide, please. So in February this year, we had a survey that we did with the healthcare workers, and there was very good feedback from the HSS, the health surveillance assistants, the healthcare workers, and 85% of them said that the system was easy or very easy to navigate, to use, and the benefits, the system had actually benefits of data accuracy. The system has got reminders where on the dashboard they're able to see which clients are due for vaccinations on that particular day. Another feature is that the system is able to send reminders to guardians or to parents that their child or themselves are due for immunization on that particular day or a set interval of time. There's also been a great government collaboration, including that I had mentioned of the DHD, that's the Digital Health Division. They have got the source code, they have adapted it into the greater MAHIS software, where there are also other modules such as OPD, there's NCD in there, and also the maternity. With that, they're able to support the system, to add more modules, to upgrade the system to later versions. And then also they're also looking for funding to actually scale it up to more facilities, because the more facilities the system covers, that provides better information for decision making at central level and even at the district level. Next slide, please. So this slide has got a dashboard, part of the dashboard that we have for the MAHIS, for the EIR. So this dashboard is actually showing us the total clients registered per week over the period since its implementation in November. So you can see that we had a total of 32,000 clients registered by March 22. And on the highest, we had about 2,490 clients registered per week. That's at the facility. So that's the just below it, we've got the clients that were vaccinated. That's 25,000. That's 24,997. And on the right of it, you'd see there's a breakdown of whether males or if they're under 5s or females. And just below it, we've got the vaccine doses that have been administered. We've got the dashboard for the MAHIS. On that link, I think I'll be able to share it in the chat, where you can be able to see how the EIR is performing in Malawi. Next slide, please. So with the DRPC project, we've got 3 priorities right now, which would actually help the system scale up and also integrate with other systems. The first one is, like I had mentioned, that the system has been deployed to 47 facilities. In total, we've got about 900 facilities in the country. So you'd see that it's a small percentage, but that has proven that the system is important, it's user-friendly, and it's scalable to more facilities. Now with the MOH, they've got a priority that they would like all systems to integrate you via the interoperability layer. So we've got an interoperability layer in Malawi that has integrated some systems. However, it would need to be enhanced so that the EIR can also use the same to connect via other system rather than having a system-to-system direct connection. The third priority for us is to now link the system with other health systems within the same immunization space. For example, we've got OpenLMIS, which has got supply chain data. So as we know, we're vaccinating the clients using supply chain data, which is also updated from another end by the same healthcare worker. So that's actually two jobs being done by the same person. The other one is to integrate with ICIS. ICIS it's an integrated community health information system. This system is being used at the community level. So with MAHIS, it is only used at the facility level. So those figures were only for facility level clients. But at community, there's another system called ICIS. So we would like to have a client that is vaccinated at the community, have their information immediately available at the facility when they come in MAHIS. And also the other systems that we need to integrate. For example, we've got DHS2, which is the aggregate system for Malawi for all health information data. So we'd like to send the information from the EIR straight to DHS2 that the other people from the central level, they can still be able to access the data and make other informed decisions rather than having to compare data from two different systems. That's from DHS2 and from the EIR. So that's the update that I had for Malawi. I'll pass it over to Isaac in Tanzania to speak about the IPC there. Thank you so much.
Yeah, thanks, Jose. So my name is Isaac Sahela. I'm the technical project manager from Digital Square, Tanzania. So I'm going to take you through the DIPC project implementation in Tanzania. Next slide, please. Yeah, so like what my colleague presented, so in Tanzania, first we conducted the ecosystem mapping for all the digital immunization systems, and then we come up with these three main objectives. So the first objective was to localize immunization in DAC, so that the healthcare is administered according to national clinical guidelines. And the second one was to support the enhancement of immunization mode within the centralized Government of Tanzania Health Operation Management Information System. And the third objective was to provide the capacity building to developers from the Ministry of Health, local entrepreneurs, and the other governments agents focus on the WHO Smart Guidelines Initiative and the fast health interoperability resource, the FIRE, to support data exchange and interoperability. Can you go to next slide? Yeah, so as a part of the second objective in Tanzania, the DIPC project collaborated with the President Office, Regional Administration and Local Government, the PRAG, to enhance the GOTOMIS. GOTOMIS is the digital system that is used at the primary health care. And it's used with more than 4,000 primary health facilities to facilitate daily service at the primary health care. So as a part of the project, the IPC, we worked with the PRAG to improve the immunization mode by incorporating the user feedback and aligning its functionality with localized DAC. This is as what also Linda mentioned. So the healthcare is administered according to the clinical guidelines to increase the quality of care. So currently the immunization model has been deployed in 3 regions of Tanzania, Arusha, Mbeya, and Tanga, across 6 health facilities, which is Korogwe, Lushoto, Tukuyu, Kyela, Ipinda, and Kaloleni. And in collaboration with the President Office, we have managed to train 63 healthcare workers to use the system. And currently, the module has been integrated to the daily activity at the facility setting. Can you go to next slide? Yeah, so this is a current dashboard that is showing the immunization mode within the centralized government of Tanzania Health Operation Management of Information System, which now the system has managed to record more than 9,000 clients into the system. This is based on only 3 regions of Tanzania across 60 facilities. As you can see from the dashboard, this is a number of clients that has been vaccinated using the enhanced immunization mode. Can I go to next slide? Yeah, so during the deployment also we managed to train, as I mentioned, a number of healthcare workers, and most of them also have been happy about the system, and as mentioned that the system also has been integrated to their daily activities. And some of the also, we have noted also some of the testimony from different healthcare workers, like one from the allies in Ghetto who said the information in the system is easy to access if needed, unlike the paper-based method, because at first the healthcare workers, they were using the paper-based system to record immunization data. So having the improved immunization mode within the EMR enabled them to track the data, the immunization data, and also to present those data when needed. But also the immunization model will help us to reduce the time spent on the physical documentation and the paper use, while also minimizing the risk of missing important data. So those are the testimony from the different healthcare workers across those 6 facilities that the solution is being deployed. Next slide. Yeah, so as also my colleague mentioned, DAPC project in Tanzania also has some of the key opportunities. So the first opportunity is to scale the immunization mode across the country, because as currently we have only deployed the immunization in 3 regions and across those 60 facilities. So the DAPC working with Pure Lab to find investment partners, a private organization or donor to ensure that the solution has been deployed to the rest of facilities. And the second opportunity is to integrate GoToMIS with other potential system. Like currently in Tanzania, we have the Unified Community System, which is taking all the health service data from the community. So there's an opportunity to integrate this EMR with the community system. But also the third opportunity is to provide the capacity building to healthcare workers to improve and sustain the system, but also to train, to provide additional training to developers, especially on the fire standard, but also fire standard in the WHO SMART guideline. So those are the key opportunities for the DAPC project in Tanzania. Thanks, and back to Linda.
Great. Thanks very much, Isaac. So as mentioned earlier, I'm going to tell you a little bit now about our global immunization product suite. Next slide, please. So what do we mean when we talk about a product suite? Effectively, it's really just a configuration of existing open source software applications, and we integrate those using standards-based workflows, and in this case, HL7 FHIR, which is really the de facto standard for health data exchange. And the idea behind this concept is actually quite simple. You know, when someone in a ministry is considering a digitalization challenge, typically they're not thinking in terms of like specific software modules that they might need. You know, like they're not thinking, I need an EIR and maybe I need a notification system or a messaging service. Maybe I need some sort of visualization tool. Instead, they have a problem they need to solve, which is how can digital tools make immunization service delivery better? And so really the global immunization product suite intends to try and address that by doing the heavy lifting, by already having integrated mature open source technologies in a way that is highly configurable and ready to deploy. Next slide, please.
Dear Linda, just as a reminder, you have around 5 minutes more.
Great, thanks. So we collaborated with ONA to develop this product suite solution. At the core of the tool is OpenSRP, which is their Fire native version of the Smart Register platform. And this is where the actual immunization register piece sits. So this serves as a reference application. There's a lot of comprehensive documentation that goes along with it, and it demonstrates how these type of Fire-based tools can be quickly adapted to meet different country needs. Just to say, this is freely available. It is an open source tool available on a GitHub repository. It's particularly valuable in a greenfield environment where you don't have any existing immunization systems in place. And what it does is it's essentially a mobile application designed for frontline healthcare workers. So whether they're community health workers or nurses within clinics, the app enables them to register patients and enroll them in immunization programs, to record all of the pertinent details around a vaccination event. And that is based on the national immunization schedule. So it will tell you, which children are due for which vaccinations. It tracks missed vaccinations and can generate follow-up tasks to ensure that no child actually falls behind. Also includes some very basic vaccine dose tracking, so helping healthcare workers to actually monitor their usage. And it is currently available in English, French, and in Spanish. So really designed to support an end-to-end workflow. Next slide, please. So the other open source component that it integrates with is Akuko, which is the analytics dashboard. It integrates with Rapid Pro, so the ability to send SMS notifications or reminders either to the caregivers themselves or to community health workers. It also integrates with DHIS2 to enable aggregate reporting. You see, this is a very widely used health management information system used widely across the continent. And I've said a lot of the time that this is something that is easy to deploy. So what do we mean by how quickly it can be deployed? So this does depend on two factors. One of which is you do have to have clearly defined requirements up front. So you need to have already gone through that process that we've just described. So the developers need to understand what it is they have to build. And then you do need developers who are familiar with the tools and especially with HL7 Fire. But that's true of any technology. If not, you just need to add in some time for onboarding. But generally, it's estimated you can take this tool and it takes about 2 weeks to customize it fully for deployment, which is really pretty fast. Next slide, please. Okay, and lastly, but definitely not least, I'm going to tell you about our gender activities. Next slide. So Isaac already mentioned in Tanzania, we did some fire training for a wide group of people. That included a number of women who participated in that, and you can see them there on the screen. And then the other event that we held was in September 2024, held in Accra. And this was our Ghana Women in Digital Health event. So this event convened around about 95 different female participants. Most of them were actually students or young professionals coming from both the health side, the public health side, or the IT sectors. And it was really intended to help them to learn about digital health and particularly the diverse roles that are included within this field. So they heard stories about women leaders in the digital health space. They learnt about how to overcome some commonly faced challenges and also to connect with some of those local digital health stakeholders. So we had some interactive workshops, which really were just designed to give them a sense of maybe the type of practical skills needed to inspire their career paths. And really the big takeaway for many of these attendees was that digital health is not just about coding, that there are many ways and many avenues to actually enter this field. So this was an awesome event. It was a really fun, high energy event. And to end off, if we do have time, Carl, we'd like to just show you this very brief, around about a minute or so, video, so you can hear what the women have to tell us in their very own words. But with that, I just want to say thank you so much for listening.
It is a great pleasure to welcome you all to this important event. This gathering comes at a crucial time as digital health continues to transform the way we approach healthcare, not only globally, but here in Ghana as well. The significance of today's conference is to underscore by our shared goal of universal coverage. And our universal health coverage says we are leaving no one behind.
The program was
empowering,
insightful,
phenomenal,
life-changing,
informative,
groundbreaking, educating,
was transformative,
enlightening, mind-blowing.
Yeah, thanks, Carl. That was the end. These are just some additional slides. So if we do share them with people afterwards, we've got a lot of additional information on this slide deck as well. But thank you.
Yeah. Thank you, past colleagues, for your interesting presentation and sharing your project with us. I want to now, before the Q&A session, we have our last speaker from Canada, Dr. Andrea Thomas, the Director of Epidemiology at Blue Dot. Andrea will share her screen to present their projects in Blue Dot. Andrea, over to you.
Okay. Thank you, everyone at IDA, for inviting me today, and to all the fellow speakers. I think we've seen a lot of incredible efforts at very local levels. I'm going to zoom out for the last talk and cover sort of what my company is doing, the company I work for, at a global scale in the infectious disease space, and how we're leveraging AI and digital technology. So I will, oops, try to share my screen. And can everyone see my slides?
Yes, we can see.
Okay, great. So we are an organization based out of Toronto, Canada, operating at a global scale. And today I'm going to talk about sort of the fight against time, how we're leveraging AI and digital technology to try to get ahead of outbreaks happening around the world. So just for a quick agenda, I'll just cover what our mission is, how we do the work that we do, specifically looking at how we're leveraging AI technology and digital tools to support global health and biosecurity. I'll get into some of the applications in action, and we'll look a little bit closely at what we're doing in the biosecurity space. So we're trying to really help the world to be more resilient to outbreaks, and we're operating at several pillars. One is in the identification, trying to identify outbreaks or infectious disease activity that demands attention, depending on who our clients or our stakeholders are, as well as helping our organizations that we work with to anticipate how infectious disease outbreaks might impact their particular workflows or their mandates. And then helping to appropriately respond. So tailoring responses, tailoring action, and making sure that our efforts are being used effectively and efficiently. This is some of the team that I get the pleasure of working with. These are really a lot of the experts behind both the development of the system and the utilization of the system. So sort of coming back to having users in the loop as we develop AI technology. Our surveillance team actually uses our technology every day. So they're one of the core stakeholders providing feedback and helping us to really improve as we develop the system further. We have combined expertise spanning from human clinical medicine, veterinary medicine, epidemiology, and public health and global health expertise. And we also have co-developed training in open source intelligence, or OSINT methods, and how to apply those to epidemic intelligence. This is some of our work over the years. So back in 2014, using our air travel models to predict the spread of Ebola out of West Africa into international locations such as London. Later in 2016, using our models, looking at distribution of vector mosquitoes to predict even down to a neighborhood level 6 months ahead of time where Zika was likely to begin spreading in Florida. In 2019, very late December, we were among the first to alert about the emerging COVID-19 pandemic and published the first peer-reviewed literature around where that outbreak was most likely to spread first. We also apply models looking at true burden estimates, because oftentimes when we're dealing with an emerging outbreak, we're really just seeing the very tip of the iceberg. And so we've developed approaches that can use air travel data, exported case data, and understand what the actual outbreak size might be in that location. And we've published on this, looking at the Mpox emergence in 2022. We also use AI, and I'll show in a little while, to predict where mosquitoes are likely to expand or contract under various climate change scenarios, looking out 10 years in advance. These are some of the clients we work with. We're fortunate that we're able to work at various different levels. So we work with multinational organizations, such as the ASEAN region member states, the Gulf CDC, the new Center for Disease Control that's been stood up as a result of the COVID-19 pandemic in the Gulf region. We work with defense organizations such as NATO. And then we also work at national levels in organizations such as the NIID in Japan, Taiwan Center for Disease Control, and down to very local levels, such as the city of Chicago, really helping Chicago anticipate what disease outbreaks might be coming their way that they may need to prepare for. We also work with private enterprise, and I think this is something that has really heightened since the emergence of the pandemic that we've just faced, which is we need an olive sector approach when we're facing infectious diseases, down to organizations that are responsible for keeping their workers safe. So we work with organizations such as Amazon, airlines such as Air Canada, among others. And why do we do what we do? Well, we're really seeing that over the last couple of decades, outbreaks are emerging more frequently, sometimes having greater impact. And we know that with all of the changes that we're facing with climate change, disrupted habitats, we're really at this time where we're seeing more and more threats emerging from around the world and having impacts. We will need to add to this. We're now 2024. I think we would definitely add the public health emergency of international concern around Clade 1b Mpox, as well as the measles resurgence that we're seeing in a number of countries. We also have growing biosafety concerns. So on one hand, we have a large increase in the number of labs working with high security pathogens, which is a good thing when it comes to research and development, but it does open up increased opportunities for accidental pathogen release and possibly more like a man-made biosecurity threat. So this is a sort of a high-level overview of our system, which is really designed around two streams of data, one being indicator-based surveillance data, which are coming in from official sources. They're highly curated, and we've extracted data in such a way that is interoperable and easy to use. And then we have our event-based surveillance system, which has been developed over the years and redeveloped as new technology has emerged, which is really gathering all of the online local media sources from around the world in near real time, filtering them down, extracting information, and providing really tailored news feeds to our clients, depending on what their areas of focus are. And as you can see on the right, we are continuously receiving human feedback, both from clients and from our own surveillance team, to continually be improving and updating the system. Here's an overview of all of the articles that have come into the system, with the sizes of the disease names representing the volume of articles. And these are millions of articles. This is sort of taking a very high-level data science approach to see what we've been monitoring over the last year. As well as the disease surveillance information that we're gathering, we also have a toolkit that allows our clients and our own internal team to conduct risk assessments. So aspects such as what is the expected seasonal burden of disease, what historical disease activity have been experienced in a certain location, risk factors, environmental and demographic, air travel intelligence, and some in-house models looking at ground movement patterns and estimating true burden of disease when we have appropriate information. So we're going to look at how we're leveraging the AI technology to support global health and biosecurity. So I'm going to take one look at, this is one of our news feeds, going back to the biosecurity threats and organizations responsible for monitoring these threats. They're looking for specific aspects such as specific high priority pathogen activity, any news around accidental release of biological agents or acts of deliberate spread. They're monitoring for unknown or mysterious illness activity. So we take a bit of a syndromic surveillance approach, looking for news around different disorders that might represent an infectious disease outbreak, as well as global outbreaks in animal populations. So we're also monitoring for local news around animal illnesses that can represent high priority biological agents such as anthrax activity. This is an example of a month of data coming into the system, into the biosecurity news feed, and how it gets filtered down. So starting with 11 million or more articles, we're extracting articles based on their titles, based on a relevant, the body of the article being relevant to what we're looking for. And then we're using models that can extract and structure data so that our clients can easily filter out what they're looking for and find the content that they need in a very efficient way. And these are being updated every 15 minutes. Here's an example of some of the articles that might be of interest to some of our clients monitoring this area of activity. And here are sort of a look at where subject matter experts are involved in the continual evaluation and training. So in the lower section, the boxes are sort of showing all of those points where we will be using human intelligence to make sure that we are continuing to provide relevant and accurate information, really trying to help save the time that it can take to do this type of work. We're signatories to the Government of Canada's Voluntary Code of Conduct. So we're really trying to make sure that we adhere to these core principles, one being transparency, so always ensuring that our stakeholders understand when AI technology is being used, trying to mitigate bias as much as possible and understand what bias might be integrated into our system as a result of various discrepancies between, areas with good reporting and poor media access, for example. We uphold a high level of security to prevent any misuse of the technology, and as well uphold accountability, ensuring that we are making sure that the decisions being made in the system are we have ownership over, and ensuring reliability. So again, constantly trying to improve and monitor the accuracy of the system. So I'll just show some applications. So one of the areas that we're trying to streamline work of our various clients is around sort of the local relevancy to them. So looking at using models that leverage population and travel time to understand how likely is disease to spread to your area from a given outbreak center. This is an example where we applied this to, I believe, a Marburg outbreak in Equatorial Guinea, looking at the locations that would be more likely at risk, where surveillance may be needed to be prioritized and screening to ensure that spread is detected quickly. This is a video showing some action. So that was really just to share how our users can develop a personalized approach to really target what they're interested in, whether it's the disease area of focus that they're monitoring, locations of interest that they're responsible for, and our system can really tailor to their particular needs and provide a daily or a weekly or a monthly update of all of the activity most relevant to them. This is another application of AI where we're looking at the distribution of Aedes aegypti and albopictus mosquito vectors under climate change predictions over the next 10 years. So we can start to anticipate where surveillance may be needed to be improved and enhanced, where vector monitoring may be needed over time, and really trying to get ahead of sort of the frontier of dengue and chikungunya and other similar diseases. And so we can leverage our system now with the improvements in large language model technology that allows us to extract information to continually be assessing and validating these models as we see disease spread over time or mosquito occurrence changing. And finally, in terms of sort of the approach that we've taken is a data as a service approach. So because we work with a number of different clients who use different tools, different internal applications. This is an example of an internal dashboard of a client where they're able to pull our information in according to what they need into their own tools, rather than trying to build a one-size-fits-all approach that we know it's very challenging to do that with a variety of different stakeholders. And the newest sort of advancement in large language model technology also enables clients who maybe want to just interact directly with our data to query the data using natural language. And I'll end with a video sort of showing that in action as well. So just ending on this slide, this is back to the slide I had shown earlier with all the different colors. Really, we do have a lot of the tools we need. This is showing in blue all of the diseases that we have vaccines for. We could actually add, one strain of Ebola could be colored in now, and chikungunya as well. And so just to end on more of a positive note, that while we have quite a number of threats on the horizon and ongoing, we do have the technology, I believe, and the tools to counter them effectively. So thank you, everybody.
Okay, thank you, Andrea, for sharing your valuable work at Blue Dot. Moving forward, we will have a Q&A session where all participants can ask their question to the speakers. But we have significantly reduced the allocated time since we exceeded the time for the event. So I would like to ask from our speakers to answer the questions as short as possible. I know that Hamish Murrow from the Trinity Challenge organization has a question from our first speaker. Hamish, over to you.
Thank you so much, Carl, and thank you all the speakers for their really valuable insights. My name is Hamish Moore. I'm from the Trinity Challenge, which is a UK-based charity founded by Dame Sally Davies, who's the special envoy on AMR here in the UK. So we currently have our innovation challenge, £1 million innovation challenge, which is seeking data and technology solutions to improve two key drivers on antimicrobial resistance in low and middle income countries that have antibiotic stock control and substandard and falsified oral antibiotics. So my question was for Dr. Michelle, and it was on the subject of this. What digital or technology innovations do you feel can make a positive impact on either of these subjects, stock control or substandard and falsified oral antibiotics, particularly at the community level in low and middle income countries?
Yeah, so you're gonna have me like dig deep back into my way back machine, but some of the earliest applications in mobile health were really around counterfeit drugs and tracking of different types of medicines and also like making sure that medical like value, particularly in the AMR space, was held. And so there are, a number of applications and innovations that exist in this space. The main challenge is really how do you operationalize them? I think, like we're really good at innovating things, right? And so anybody can come up with like a really great idea that will get, something out there. And so I always have a challenge with innovation challenges because the challenge isn't in the innovation. We have a lot of innovations. The challenge is in the operationalization. It's like, how do you get into environments and really understand what's happening? And I think we need to go back to basics. Like, we used to, in the early days of mobile health and digital health, we did a lot of user-centered design, a lot of ethnographic work to really take a look at not just like how are people using technology or information or any of these things, but like even just like basic health knowledge and appreciation and activities to then really figure out, okay, like if and when technology actually makes sense to like bring into a situation. And so I would encourage you to take a bit of a step back, as part of your innovation challenge and think about, okay, what is actually really happening? Like, who are you really trying to engage and help? What is going to be important to them and what are they going to value that, you can then link up into existing applications for the problem that you're trying to solve, and like what's going to be the most appropriate in those environments. And sometimes it's not acting directly with individuals, but like health workers or systems. And sometimes health workers don't know, some of the basics around adherence to treatment that would make drugs much more useful and valuable for longer periods of time. So I think those are some of the things that you may want to like contemplate. Sometimes the best solution is not a technology solution, it's a people solution more than anything else.
Thank you so much, and 100% agree. You know, this challenge is all about being people-centric and community-centric outside of some of the more traditionally served areas of these innovations and interventions. Carl, I know you're short of time, so I will drop a link to the challenge. Some of the points that Patricia made are absolutely questions that I hope people will answer in their submissions. The challenge closes at the end of this month. So please, if you're interested, do take a look and share. Thank you.
Yeah, thank you, Amish. I know that Iris, my colleague in IDA, have a question from Dr. Kumar Rana. Iris, can you share your question?
Yes, thank you, Carl. I have a question for Dr. Kumar. What are the policy gaps in the digital health quality standards? Specifically in the infectious disease space, and what would be your suggestion for filling the gaps in this area?
Thank you, Iris. Thank you very much for this question. I think, yes, see, as the things have been changing for the last few years in telehealth and digital space, there are a lot of discussions around that, how we should adjust the need of our digital health in regulation and the standards. And therefore, the things that the platform which are being used and developed for delivering telehealth services or even digital health, they are required to be in compliance with regulatory standards as well as any other standards which is prescribed by the national governments. And the accreditation standards provide a broad framework for those platform providers, developers, as well as service delivery partners to use that framework so that they are assured that they are providing the telehealth services as per the law of the land, whether it is which country, because the law will change and some may differ. And also, they are also in compliance with the medical ethics which are required. So I think things have started evolving, and we have seen a lot of developments more on the platform development, software development side, rather than the delivery part of it. You know, because I reviewed couple of platforms which may not be even complying with basic requirement for telehealth standards. For example, the basic requirement is that if you have a list of doctors on your website or a telehealth platform, you should also list the medical council registration number, you know, the legal number you are licensed to practice. But most of the cases it is not there. So similar, just one example. So I think the standards can really help, but the unfortunate part is people and organizations don't want to make use of the standards. That is the pity. Thank you.
Well, thank you. And my question to Dr. Thomas, actually, what opportunities and challenges do you see in implementing One Health's approach in the area of digital innovation and infectious disease surveillance?
I guess, there's many challenges. I think in the terms of what we do, it's really, one is interoperability of data and making data really easy to use and easy to access and integrate, because we see, data are shared maybe publicly, but they may not be in a format that is easy to integrate into an existing system or with existing data structures. So part of what we do is actually structure data in a way that it is very easy to use in a system that's combining different data sources. So that's just one, but I think we can see right now with the H5N1 outbreak the many challenges with really operationalizing One Health in a way that can respond effectively to these outbreaks that are really shared across species.
Thank you for your insightful ideas. I can see in the chat that someone asked from or speaker from PASS that presented from Ghana. You mentioned that the additional devices will be bought by the project, or the approach is collaborate with other programs such as the malaria program, or have access to the devices when possible. So how is the cost effectiveness regarding the implementation of the project is measured? Do we have a Gideon from PASS that can answer this question?
Okay, let me jump in. I'm not sure if Gideon can speak now, but just to say, so an actual cost effectiveness study is really beyond the scope of this project. But as I said, these are very much has been a country-led initiative. So we have been working the whole time very closely with the Ghana Health Service to understand how we can support them better. So this was one of their requests, was additional devices. But we also know that this can be problematic if this is not done in line with what they need in terms of being able to support and maintain those devices over the long term, understanding the type of devices, the sort of operating systems they're running on, and that sort of thing. So we have been doing that quite carefully with Ghana Health Service. And I think this also speaks to some of what Patty was saying earlier, just a +1 to the point that building these systems is often just the easy part. It's operationalizing them and actually keeping them going over the long term. That is the actual really challenging part. I hope that answered the question.
Yeah, thank you, Linda. And thank you all for your active engagement in the Q&A session. We shared the link to our call to action in the chat. And I invite you to read and sign it. We urge governments, funders, technology leaders, and public health stakeholders to take bold action. So I briefly review some of our targeted recommendations. For example, we recommend to establish a clear regulatory framework for digital health governance, ensuring data privacy, cybersecurity, and ethical AI deployment. And also, we recommend to integrate digital diagnostics, remote monitoring, and telemedicine into routine clinical practice, and demand accountability from policymakers on digital health equity comments. So IDA invites you all to join this movement. Together, we can harness digital innovation to build a healthier, more resilient world. And about the closing remarks, so in our session today, we understood the role of digital innovation in enhancing infectious disease surveillance and response. And we also learned about some practical strategies for implementing technology in public health systems. And some of our speakers touched the ethical considerations for the responsible use of digital health tools. And it was an opportunity for collaborating with global leaders and innovators. And we got some insights into the latest research, technology, and trends shaping global health strategies. So thank you for your time, your dedication, and your commitment to global health. We look forward to continued collaboration and progress. Thank you all.
Thank you. I learned so much. Thank you. Have a good day.
Thank you.
Have a nice day, everyone.
Bye, everybody.